I'd say 50% of the time you have to move the patient to a place where you can actually work on them, because they're in a bathroom, they're in a bedroom, it's very tiny, very tight, there's not enough room to work. You need to have enough room to work with the big crew, with any resuscitation. If you have limited resources, CPR and defibrillation are the first priority. Incident command principles are followed. So, the first arriving paramedic is the team leader for the resuscitation. First arriving company officer will be, I love these things, it takes me back to the military. Fast attack incident commander. Responsible for non-medical management of scene, safety, and liaison while assisting with resuscitation. Second arriving company officer is strategic incident commander, who is responsible for non-medical management of the scene from the tactical incident command and remaining in strategic position. Uninvolved in resuscitation if possible. Now, that's really only possible where we have lots of people. Position 1, pit crew. Compressions determine cardiac arrest, unresponsive pulses, expose the chest, begin compressions. Announce when your compression is 180, 190, and 200. That's to give the defibrillator medic the chance to charge the machine and get ready for possible defibrillation if there's a shockable rhythm. Position 2 is the life pack. Turn on the life pack to time stamp the beginning of CPR. Start the metronome. Apply defib patches. I prefer AP if possible. And if you're going to use the Lucas, it's where you want it. And if you haven't placed it, switch it if you have 3 unsuccessful shocks in VFib pulses VTAC. Monitor compression quality, speed, time intervals. Charge the monitor at compression 190. Interpret rhythm and shock if indicated after compression 200. Alternate during compressions if needed until additional resources. So if you have a full crew there, you're always on that life pack. Position 3 is airway, and that can be and is in our system an EMT basic, because we've trained all the EMT basics to put the iGel. Oxygen by nasal cannula, says 10 liters, you can actually put it on apneic oxygenation, you can put it up to 15. They're unconscious, they're not going to be bothered by that. BVM ventilation after the first defibrillation. Insert the iGel after the first or second defibrillation. Provide ventilations on the upstroke. Attach ETCO2 monitoring. Suction as needed. Now, by law, can the EMTB interpret the CO2? No, but you can read it and say to the paramedic, CO2 is 24. Intubation should be done if required for airway control and doesn't interfere with compression. We will talk more about this in the latter part of the day. Position 4, compressions, alternate compressions. Position 5, IV, IO, and meds. Start the IV, IO. 1 IV attempt prior to IO insertion if you can't find a site within a minute I want to see an IO in there, I prefer that you go into the humerus. As you can see, there's a humeral IO in this demonstration here. Administer required medications as called out by the team leader. Position 6 is strategic IC, basically safety, liaison with family and other agencies, develop an egress plan. Position 7 and 8 are backup assigned as needed, and additional personnel, if needed, will be assigned as needed. So this is basically a schematic where we would have these people positioned with their life pack positioned, an airway and life pack, compressors, able to rotate, IVIO meds and med kits, and then additional personnel. After the incident, company officers should debrief crews, that's the plural, if possible. Debrief crews after each cardiac arrest call and determine where improvement can be made. Talk about issues, talk about problems. Come up with some suggested solutions. How could this have gone better? How could this have gone worse? All personnel should review the CPR process file, or at least the dashboard, to determine how it can be improved. Now, it's difficult when, I realize there's a difficulty because you're going to download that CPR process file either at the station or at AMR, and so sometimes the two don't cross paths. We'll try to work on that more. So 10 basic principles, EMTs on CPR. Again, minimize interruption of CPR at all times, ensure proper depth of compression, 2.2 to 2.4 inches, ensure full chest recoil and decompression, ensure proper chest compression rate, 100 to 120 a minute. Rotate compressors every 2 minutes, hover hands over the chest during shock administration, intubate or place advanced airway with ongoing CPR, place IV or IO with ongoing CPR, coordinate, and teamwork with EMTs and paramedics. So AHA changes. The AHA over the last 5 years has adopted a new policy of upgrading every year, making changes. And as the science changes and as they get a group of really smart people together to figure out whether things have changed or not. It used to be every 10 years, then it was every 5 years, but almost always when we had the update at the 5-year mark, we were already ahead of that update. It takes a while for medical literature to catch up. It takes time. And the science has to be peer-reviewed now quite extensively, and the rules are there. So, the AHA changes in 2020 are not anything that's unknown to us, basically. Advanced airway, they've said, even in places where you have, and we will fit into the category of an EMT intubation high success area. The whole West Coast, except for California, where they don't allow EMT or paramedics to intubate in at least half of California states or counties. But Oregon, Washington, and Idaho are high success rate intubate. We've been doing intubation, paramedic intubation for 35 years now, 40 years. And we've been doing RSI for almost that same amount of time. So we have a very high success rate. But even in high success rates, that varies between 85% success and 95% success, which would not be acceptable in a hospital. You'd want to see higher intubation rate than that. But, so they've said, even in a high success rate, that you could use either an SGA, a supraglottic airway, the iGel type thing, or an ET tube. as your definitive airway. So we've done both. And that's perfect. So our normal thing is to use the iGel if there's an indication for ultimate intubation, then we'll do that as well. Epinephrine. Well, epinephrine is still recommended as, if you're going to use it, at 1 milligram every 3 to 5 minutes. High doses are not recommended. There's no decision yet as to what is a high dose. To me, 5 milligrams over a total period of an arrest is probably too much. But we don't have any science that guides us on that. Vasopressin has been checked out again, and still is no advantage to use vasopressin at all, so we don't bother with it. Epinephrine should be, there is consensus though that you should administer it as quickly as possible if you have an out of cardiac arrest, or an out of hospital cardiac arrest that starts as a non-shockable rhythm. In other words, a PEA, a rhythm with no pulses, or a systole. Okay, so as quickly as possible. However, in a shockable rhythm, they don't recommend epinephrine until after the initial defibrillation attempts have failed. Now, what would initial defibrillation attempts be? 1, 2, 3? We don't know for sure. I would say don't give epi in a VFib arrest until you've done good CPR and shocked at least twice. And really, that's all the changes. There's no change in the recommendation.
Dr. Woodward, just to clarify, right? Is it okay to piggyback the epinephrine right at the second shock, or do you want a full cycle of shock? Does that make sense?
Well, you don't know. I would do the full CPR cycle because you don't know if that's, we're not peaking, so we don't know if that second shock was effective or not.
Copy.
Okay. There's no change in the recommendation on any of the antidysrhythmics, both, at least in some studies, amiodarone and lidocaine appear to be equally as effective. I've opted for using amiodarone primarily because we use it for other stuff too. You get more familiar with it. In pediatric resuscitation, they're suggesting that BVM is reasonable compared to using an advanced airway. Now, that's kind of the most point for us because, so a BVM is most effective even in pediatrics with an oral airway in place. But if you have a pediatric resuscitation, we have the full component of pediatric iGels, which is even better. And in neonatal resuscitation, 35 weeks or greater, they want you to start with respiratory support with room air, not 100% O2. They do not use 100% O2. Room air is the thing to start with, and they did have some pretty good case studies which showed that using high flow, high oxygen in newborn resuscitation, there were a lot more children who did not survive. Okay, very quickly, I think you've probably seen some of this stuff. We don't have the new WalkCares updates this year, but WACARES is a cardiac arrest registry to enhance survival in Washington. WACARES developed to help us do basically data analysis of hospital cardiac arrest to try to get to see where we could do quality improvement. In Clark County, over the last 5 years, this is our survival. The orange is sustained ROSC. You can see our ROSC has always been good. Sustained ROSC means that they got ROSC and you transported them to the hospital, and they sustained it throughout that period. The yellow bars are survived to admission. So the difference between sustained ROSC and survived to admission means that those people died in the ED. And then the sort of duff-colored orange or yellow is the smaller bars are the survival to discharge. So our survival to discharge overall has been slightly improving. There's been some better and the problem is that even with our numbers of 271, 233, 224, etc., it's not enough numbers to say there's any significant statistical significance between any of those numbers. So between 14 and 16% ultimate survival, no difference statistically. Probably all indicates that we're doing really good CPR. This is almost identical to the Multnomah County, the Clackamas County, and the Washington County data. It's all because we're all pretty well trained in the same stuff. Now, Utstein survivors, Utstein is not a person. Utstein it's a monastery in Norway that has been converted into a conference center, to a big meeting place, kind of a fancy place. And so they got all the smart cardiac guys together around the world, and they came up with what kind of things would likely de novo predict the best survival from an out-of-hospital cardiac arrest. And of course, one of the things is witness arrest. The next thing is citizen or bystander CPR. The next thing is early defibrillation, and even a subcategory of that would be defibrillation by an AED available to the bystanders. Then time for arrival of first responders, time for, and really, there's almost nothing in that equation that has to do with delivering medications. So, the best Utstein survivor would be if you see someone collapse in front of you, you immediately call 911 and start compressions, and someone comes running up with an AED and you shock them, and then the first responders arrive. That would be your best. You say, well, of all things, and a shockable rhythm is the other thing. So with those things, those would be, you expect those people to survive. Well, of course, they don't always do that. And so all the things in that, so the Utstein survivors represent that group, and the orange is Utstein survivor rate, and the yellow is Utstein survivors with bystander CPR. Curiously, it doesn't always work out this way. So we had one year where our host time was very, very bad. I don't know why, 217, but we're back up at 42%, which is Multnomah County's at 36%. Probably also not statistically significant. And curiously, our bystander survival rate is less than the overall survival rate. And the only way I can interpret that is that, and looking at the cases, is that the people were really sick. There were a lot of cardiac issues and non-cardiac issues with the people, and they just happened to be sick enough that there almost always was somebody at home with them, and they'd already been told how. And we have a lot of citizens of telephone CPR instructions now too. One of the other things that I noticed, which is kind of interesting, is going back here, is that curiously our numbers of cardiac arrests in Clark County have been falling over the last 5 years. I don't know why. I can't determine that people are getting any less large out there, or nor are they getting any more healthy. Maybe we've depleted the stock. I don't know. I hate to think that. And then we have a little bit of benchmarking for the hospitals too, because we do look at the hospitals, and this is and so in Clark County only Southwest receives the ROSC's cardiac arrest, you can see there the statistics are pretty much for the state, and it's a very high performance state, Washington, compared to the next. So 34%, 35% of people who seem to die in the ED if they're brought in with ROSC. About 65% are admitted to the hospital. Is pretty around the country. That's only 43%. Discharged alive, the ones admitted. So that's a subcategory of all of the arrests. So we had 25% discharged alive. Nationally, it's 16%. So that's a significant number. I mean, when you percentages don't, when you're looking at the, so that means you've got 25 people out of 100 that is discharged compared to 16 people out of 100. That's a lot of live people. And our CPC, the CPC is a neurologic scoring thing. Our CPC score is good, also 24 to 25%. Nationally, 12%. So it means twice as many people who are discharged, who survive, are neurologically impaired in other states, nationally. So that's all pretty good. So when we're looking at our slide set to talk about update on cardiac, we did have a whole slide set on the life vest. We haven't seen a life vest put on for about 4 years. So I don't think you're going to see one, and I'll warn you. I guess I'll get warned if we get one out there. And why don't we use the life vest? Was a temporary method. It was a method to you had a person who's had a cardiac arrest from ventricular fibrillation, pulses VTAC. They survive, you take them to the cath lab, they don't have any coronary artery disease or anything significant to treat, so you assume that they're going to have, then they have a structural problem that needs to be managed with, they're going to do this again, and so you'd like to put in an internal cardiac defibrillator, but for some reason you can't. Usually in the past it was because you couldn't get approval, or couldn't, or your doctor wasn't sure, or they didn't have the device available, or they couldn't do it at the hospital you're in. Nowadays, we do them right there in the first, within 1 or 2 days after they're admitted to the hospital. So you're probably not, you're going to see AICDs, but you're not going to see the life vest. Then, we still have left ventricular assist devices. I'm not seeing a lot of them recently. I mean, there's a couple in the community. The left ventricular assist device is a mechanical heart. It's a device to assist the left ventricle, the left heart, in pumping blood. So you've got blood pumped through the LVAD into the aorta, gets into the LVAD from the left ventricle, and then it's pumped. Then it's got a circuit that pumps into the aorta, so you're just assisting the left ventricle. There's a control unit, there's batteries, there's the whole works. So it's to assist the function of the left ventricle. It's got pump inflow from the left ventricle, pump outflow to the aorta. The device uses a wearable system, it's a small controller to an internal pump. It can also be plugged in at home to a 110 or 12 volt power, or in your rig to a 12 volt. Now, if the patient has an LVAD and they're calling for a medical or a cardiac issue, to assess the patient with an LVAD, establish airway, provide O2 if there's any respiratory symptoms. If the patient's having a medical emergency, that's not necessarily the issue that it's a device issue. So, for example, we have had at least one patient transported to Southwest that was having a stroke, which might have been from his LVAD, because the thing is a mechanical device, so it can cause some clotting sometimes, but there really was not a problem with the LVAD per se. And so you didn't have to do anything with the LVAD. And it was okay to take them to a non-LVAD center. Obviously, you take a person to, if they're in a dire emergency, like a true cardiac arrest, you take them to the closest cardiac arrest capable hospital. So consider the whole clinical picture. Now, infection, volume depletion, stroke, bleeding, and dysrhythmias are often the cause of the patient's symptoms. Most LVAD patients are anticoagulated, so they're at risk for bleeding and hypotension. Now, to assess the LVAD, auscultate the heart sound. See if the device is functioning. It makes a noise. It's a whirring noise. They're continuous flow devices, and so you hear it constantly. So, because they're continuous, what else is the problem if you have a continuous flow device? You may not be able to feel a pulse. These devices, so assess other signs of circulation, capillary refill, dizziness if the patient's awake, temperature, moisture scan, EtCO2. What does that tell you? It tells you if the patient's perfusing their lungs. If they're perfusing their lungs, they're probably perfusing the rest of them too. Start a large bore IV, treat with fluids as needed. Standard blood pressure devices may not work. Entitled CO2, other clinical signs, capillary refill, mental status, etc. Pulse oximetry may not be accurate due to continuous flow as well. Now so you can get a reliable EKG, those are hardest, so if you have an EKG that says, ventricular fibrillation. Could they still be alive and talking? Yeah, the LVAD is still functioning, if it's still functioning. So not all dysrhythms may be symptomatic. If the patient requires defibrillation, leave the pump running and in place and defibrillate. Now, if the patient's looking at you, talking to you, please give them some perception. LVAD patients may also have an AICD in place. These poor people have been, wired for everything. Do not place defibrillation pads directly over the pump, because mechanical, electrical driven things do not like to have a direct DC shock to them usually. All ACLS medications can be used. I mean, any ACLS med, not all, you don't want to use them all. If you hear a whirring sound, do not perform chest compressions unless you're instructed to do so by the LVAD center. Now, the LVAD center is now, the main one is Providence, St. Vincent, but they're coming back online at OHSU. OHSU had a little problem with their LVAD center, not with the center itself, but the fact that all of their cardiovascular surgeons quit. And now they're hiring new ones. Only perform chest compression if the pump is not operating. So, transport an LVAD patient to the closest LVAD center, call the number, the LVAD coordinator. Now, you've got the numbers in your protocol. The LVAD coordinator is one on call all the time, 24/7, 365, and they may tell you to go other than to St. Vincent or to OHSU or whatever. They may say go to the closest hospital, particularly if you're in a cardiac. But most of the patients who you're having issues that are related to that, it's better to be at the LVAD center because they have all the history, they have all the everything. So you may have to go out of county for that. The patient has to be supported by battery power. Also transport their backup controllers and spare batteries. The controller should be kept close to the patient. Don't link the leads or sever the drive line. Don't put external pressure on any area of the LVAD system. Put gurney straps underneath the leads. Keep the batteries easily accessible. If there's a trained caregiver, there usually is, they can come with you. They should come with you. Bring